This video is about journal examination in relation to CVS. Look at the nail of the patient for clubbing, chylonychia, cyanosis, splantar hemorrhage, tobacco stain. Tobacco stain is found in smoker responsible for ischemic heart disease. Splantar hemorrhages are found in infectoendocarditis. On the other side, we will look for the same clubbing, chylonychia, cyanosis, and splantar hemorrhages. Now we will turn the hand and will look for ossular nodes. Ossular is a red raised, palpable, tender nodules on pulp of finger as well as thenar and hypothenar area. Genuine lesions is a non-tender red maculopapular lesions on a palm or pulp of finger. We look for xanthomata as well, palmar or tendon xanthomata, which is related to atherosclerosis of ischemic heart disease. Now we will look at the pulse. We laterally flex the hand and palpate the pulse with three fingers. We will look for the rate, rhythm, volume, character, condition of the vessel wall, and radiofemoral delay and radial delay or inequality. Comparing other pulses simultaneously, carotid pulse should not be seen at the same time, may cause syncope due to cerebral ischemia. Volume and character of pulse are better seen in brachial and carotid artery. Collapsing pulse are seen in aortic regurgitation and pulsus alternus is seen in left ventricular failure. Collapsing pulse and pulsus alternus are better feel in radial artery. Now we will go and look for the radio-radial delay. It is very important to look for the radio-radial delay because it signifies important pathology. Now here we will go for radiofemoral delay. Is there any radiofemoral delay or not? Because the same is like radio-radial delay, it is also very significant and signify a different pathologies. Once we are done with pulse, we will go and check the BP. For checking the BP, it is very important that hand should be at your level. We will close the cuff two finger above the brachial artery and will put the steth here and will check the BP. Do not lower down the arm or upper the arm because it undermine or overestimate the BP. Here we will look at the GBP, any palpable vein at the neck area. Normal GP is raised 3 cm above the clavicular line. If it is more than that, it is always pathological. And we can also look at the waves at GVP. We will look at the carotid artery. There are some pathologies in which carotid artery are visible like Dance's carotid and aortic regurgitation, also a Corrigan sign and aortic regurgitation. There is a fixed risk GVP and obstruction, superior venous obstruction. We look at the carotid artery between sternocleidomastoid muscle. Here we will auscultate the carotid artery for bruit. It is very important, especially when you are examine patient for a cerebrovascular accident in order to check the carotid bruit. For carotid bruit, you will put a stent between the sternal and clavicular head of sternocleidomastoid. Now look at the face of the patient. Look for the molar flush and narval stenosis. Look for the morphinoid faces. Look at the lips for cyanosis. Look at the corneal arcus and xanthelasma, which may be related to atherosclerosis and ischemic heart disease. You can also look for Argyll-Watson pupil. Also look for anemia as well as jaundice. Anemia is responsible for ischemic heart disease and congestive heart failure. You can also generally look at the patient, the dyspneic or orthopneic. Look at the leg of the patient. the cyanosis, clubbing, chylonychia, everything. And now look at the dorsal pedis pulse on the both side and posterior pedial pulse on the both side. This is the area where we palpate the posterior pedal pulse and dorsal pedis pulse. Now look at the legs, look at the hair loss and peripheral vascular disease. Also look at the edema. Pitting edema is found in congestive heart cardiac failure. You can carefully look at the lower limb and will cover the lower limb at the end of your examination. Always say thank you.